Hello, welcome to this next installment of Physical Therapy Management of Older Adults with Hip Fracture. My name is Kathleen Mangione. I'm a professor of physical therapy at Arcadia University in Glenside, Pennsylvania, and I am one of the authors of the Clinical Practice Guidelines. I'll be describing the post-acute period, and that's really the home care and community settings. That period after acute care is the period most marked by extreme variability. Now, within our country, within the US, services vary very much by payer. And so some people may get acute care, subacute care, home care, and outpatient, where others will get very limited post-acute rehab and get nothing after very limited visits in home care, or perhaps very often no outpatient. Between countries, the variability is even greater. Some places, the only care they get, some countries would be in hospital or in inpatient rehab, and then nothing afterwards. So this period is really greatly variable. And in the CPG, we basically ask the question, does an extended exercise rehabilitation program offered beyond whatever is regular for you, for your country or for your region or for your patient with a specific payer, does that improve physical functioning compared to usual care? And there is a great systematic review by Mohammed Awais from Canada, which really was very comprehensive at the time in 2012, and showed that extended exercise programs do indeed positively impact knee strength, knee extensor strength, balance, tug times, and fast gait speed. Another level 1 evidence, again, highest quality evidence, from a randomized controlled trial, shows that indeed extended exercise improved physical activity levels and decreased the number of sedentary participants. And this program was year-long. It was multi-component in that it provided environmental assessment, PREs, progressive home exercise, and physical activity counseling. And all of this, again, was compared to standard care. If we look at in detail for some of the clinical things that we can take from the systematic review, if you look at home-based versus community-based, because they are separated like that, the home-based programs, both of them vary greatly in the number of sessions offered. So sometimes from 0 to 56 if you're looking at the home-based, and in the community-based 16 to 80. Home-based exercises typically were done daily for 30 to 45 minutes, whereas in the community-based, it'd be 2 to 3 times a week for 45 to a little bit over 2 hours. So we see great variability in some of the prescriptive aspects of this. In terms of intensity, it varied greatly with each and every study, from just a simple kilogram to 100% of the 1 RM. And it was found that higher intensities typically are associated with better outcomes. The sets were consistent across settings, 2 to 3 sets per exercise for each muscle group. When we look at the effects, so what did he actually find in that systematic review is that there were basically moderate effects of extended exercise on the various measures. So balance measures improved, what we would say is moderately, an effect size of 0.32. Lower extremity strength, a stronger effect, all right? Gait speed at 0.42, and then physical performance measures like the tug would be 0.53. So absolutely a moderate effect. There was no difference in self-reported physical functioning as by something like the SF-36 or in ADLs, which are usually, by the time you're in extended rehab, are usually at the ceiling at that time. They did not report on, Awais and colleagues did not report on health quality of life. Level 2 evidence, again, not as strong, but still providing some recommendations and some evidence for our final recommendation. Magaziner and colleagues, of which I was a part of that study, we looked at strength and endurance training versus active range of motion in TENS. And although both groups improved similarly, there really was not a difference between groups. And that was a multi-center trial. Another one looked at 10 weeks of home-based exercise and gait training compared to nothing, and did see improvements in gait speed. And a final RCT by Barb Resnick and group also down in Maryland found a year-long exercise program with physical self-efficacy training did improve the number of hours exercised per week. So again, each of these studies has something that we discuss in the RCT that makes it less than grade level 1 evidence. So this body of evidence, all right, again, a really strong systematic review, some really strong RCTs, lead us to the grade that it's an A-level recommendation, that clinicians must provide opportunities for additional therapy if strength, balance, or functional deficits remain beyond that 8 to 16 weeks after fracture. And that is whatever that typical time period is for your patient population. The types of exercise that we're talking about that have been reported in the literature are very clear that it's PRE training, balance, function, and gait training, and they will address the existing impairments, the activity limitations, and falls risk. Programs can be provided as outpatient services, home exercise, or evidence-based community programs. What's missing? I hope you're thinking that there's something that seems to be missing, and it really should be, we should be talking about physical activity interventions. So there was one systematic review, level 1 evidence, all right, a strong review that found that improved levels of physical activity were as measured by upright time, steps per day, and performing exercise when the programs included strength training, motivational training, and comprehensive geriatric care. So really doing those other kinds of exercises and motivational training improves all physical activity levels, again, steps per day. Level 2 evidence shows that motivational interviewing improves physical activity, all right? And this was an RCT by O'Halloran, I hope I said that correctly, in 2019. Those who received the motivational interviewing had higher physical activities, better mobility, and self-efficacy and health-related quality of life. And again, finding the activity that the person thinks is meaningful, we already know is going to be much more helpful in really improving overall mobility. And then there are a few level 3 grades of evidence that we thought we would share that we thought might be important. If it's just multidisciplinary care, Zussman reports one of the RCTs that was mentioned in the first systematic review was that multidisciplinary care compared to nothing really didn't show any kind of difference in physical activity. And then aerobic exercise, added to structured exercise, showed indirect evidence, all right, indirect evidence of safety and possible improvement of function. And those 2 studies that were reported in a systematic review by Haldol, one was by Dr. Ellen Binder out at WashU, and they did, the trial used stationary cycling in beginning of a exercise program where they would do 5 to 15 minutes of stationary cycling. The intensity was not individually tailored, but it was just that the resistance was set at the highest comfortable level that was safe for the participant, but no heart rates or anything like that were performed. I would think of it as the warm-up that was done for 5 to 15 minutes. In a trial that we did much earlier in the early 2000s, we did a little bit more of a traditional aerobic training program so that it was mostly done with walking on level surfaces or stairs. And if it was raining, we would do standing, lower extremity active range of motion exercises, marching in place, et cetera. And we're trying to do that till we got to a target heart rate of 65 to 75% of age predicted max. If they were on beta blockers, we used the perceived exertion scale. We were using a 3 to 5, that moderate level on the 0 to 10 scale. We monitored heart rate through a polar monitor or perceived exertion scale. And that evidence combined led the team to put a grade A recommendation that physical therapists must provide recommendations to patients to maximize physical activity. The physical activity guidelines from the CDC, there is no one who really doesn't benefit from physical activity. The evidence about aerobic training specifically, we would grade as a C, that physical therapists may provide aerobic training in addition to resistive training, balance training, mobility training for patients after hip fracture. But we have to consider this very important aspect as well. And so we know our disease or disorder of interest is hip fracture. And if we look at the ICF model, we know that there are body function and structure problems, impairments in strength and balance. There are activity limitations, gait speed, tug things. And we know that patients are not getting back to the activities that they love and enjoy. And so my final message would really be to promote participation in that extended rehabilitation time so that patients can get back to that prior level of function and be fully engaged in the community. Thank you so much for your time.